Okay, this is chapter 16, intrapartum fetal monitoring. We talked about antepartum fetal monitoring before. This is intrapartum fetal monitoring. When we look at intrapartum fetal monitoring, we're basically talking about monitoring of the fetal heart rate. And there are many different ways of doing this. The most common methods historically have been intermittent auscultation, where you use a stethoscope, listen to the heartbeat, you count for 15 seconds, multiply by 4, and you have the heart rate per minute. More recently, we've had external continuous electronic fetal monitoring and continuous internal electronic fetal monitoring. And we're going to look at each of these. The question I have for you is, which of these methods has the best outcome? And the answer is, they are all equivalent. There is absolutely no evidence that electronic fetal monitoring gives you a better outcome than intermittent auscultation, but we have got to where in our society, in America, the standard of practice is electronic fetal monitoring. And if you don't do it, then you're holding yourself out for liability action. And yet there is no good evidence that one is any better than the other. Here's a papa who is trying to hear the fetal heart rate. This is very difficult to hear because the fetal heart tones are a very low frequency, hard to hear. You've got to have a bell, like this wooden fetoscope that I got from Amsterdam. Here is a metal one. You can see this is a little bit younger obstetrician. This is the DeLee stethoscope, or fetoscope, which was developed by Dr. Joseph Bolivar DeLee. We use this for many years. You hold it with your forehead. The disadvantage is a mother can't hear the fetal heart. And that's a method of bonding, is for her to hear her baby's heartbeat. This is the Hahn fetal monitor. Edward Hahn was a graduate of Loma Linda University School of Medicine. He went to Yale University and developed this fetal monitor that cost at that time $10,000. This was in the late 60s, early 70s. You know what you could buy for $10,000? You could buy a house for $10,000. Why did Dr. Hahn go through all of the effort to construct this fetal monitor? The reason is, it was felt at that time that the cerebral palsy had its onset during labor. And if only we could identify the fetus that was in trouble early and deliver that baby, we could eliminate cerebral palsy. What do you think? It's a great goal. He had good goals. Did it work? This was an article from the New England Journal of Medicine, 2003. Can we prevent cerebral palsy? And the summary of the article was, at this point, little evidence that we can. And when you look at the data, the time when cerebral palsy originates in most cases is not in labor at all. It is antepartum. Only 4% of cerebral palsy is due to intrapartum events alone. In red, you can see cerebral palsy in developing countries over the last 30 years. It really hasn't changed significantly. What has happened to the cesarean rate, however? What we've done with our fetal monitoring has increased the cesarean rate, but really hasn't done a whole lot to change the cerebral palsy rate at all. Electronic fetal monitoring does not identify the preterm neonates who develop cerebral white matter injury, and the evidence would suggest if it's going to happen, it's probably already happened, and the fetal monitoring just finds out the baby that's going to do poorly, but doing an emergency cesarean probably does not change the outcome. However, you're going to need to know this for the exam, so let's go through this. The external sono device, which is for picking up the heart rate before labor, we've already talked about. This is a Doppler device that sends a signal, and the signal reflecting back is at different velocities depending on the speed of wherever it is hitting. And if it's moving heart, which is reflecting the sound back, we're going to pick that up. We already talked about the external Toco device, which picks up the uterine contractions. And here's the patient with the external devices on. The advantage is the cervix does not need to be dilated, the membranes don't need to be ruptured, and you can do this before labor. The disadvantage is it's not quite as accurate. If you have a 400-pound mama, you're not going to pick up the contractions as well as if she is 100 pounds. And the same thing with the fetal heart rate. For that reason, we will often use an internal scalp electrode. This is my thumb and my fingers. This is the tip of the scalp electrode. This wire which is on the end, this needle, is about the size of a 28-gauge needle. Very, very tiny, smaller than an insulin syringe. We don't screw this into the baby's head. We attach it gently to the superficial layers of the scalp. Here we see the maternal QRS complexes, which are the large signals, and between them are the smaller fetal QRS complexes. Let me show you this a little bit better. You can see the big maternal ones. Look at the fetal ones. Here's one. This one is hidden. This one is hidden. You can barely see this one here. This one is hidden. Here's a fetal QRS. Here's a fetal QRS. Can you see these here? Okay. What the fetal monitor does, it measures the interval between the QRS complexes, and using a reciprocal function, it then comes up with an instantaneous fetal heart rate per minute. The fetal monitor does only one thing, and that's calculate the instantaneous fetal heart rate. That's all it does. It does it very well, but that's about all it does. Now, does it help the outcome? Here we have the scalp electrode, which is on the fetal head, and it picks up the QRS complex. We subtract the maternal QRS, and now we have the instantaneous fetal heart rate tracing. We can measure the strength of the contractions using an internal uterine pressure catheter. And here you can see the catheter goes down through the cervix into the uterus. And the whole idea here is it measures the hydrostatic pressure. The hydrostatic pressure should be equal throughout. Then the paper, which comes out the machine, has on the top the fetal heart rate, and here we have the contractions. And here's a patient in labor. I happen to know her quite well. Right here in this uterus is my son. This is my wife in 1976 in labor. And that's the end of fetal heart rate monitoring.